All right, let's jump right into the emergency room for a medical mystery that is, well, just a true nail-biter. We're talking about an 82-year-old man who is right in the middle of a life-threatening crisis.
So picture this. An 82-year-old man is rushed into the ER. He's got a fever, he's having seizures, and he's making these really strange involuntary movements. Now, your first thought might be a stroke, right? A neurological event, but what if that's not the whole story? As you're about to see, the truth here is way more complicated. Okay, so this all starts with a patient arriving in critical condition. He's not just sick, his body is in the middle of this catastrophic multi-system failure, and the symptoms? They're a confusing and really dangerous mix.
So when he gets there, he's barely conscious, severely dehydrated, and his limbs are just moving in this uncontrolled, bizarre way that doesn't really fit any textbook diagnosis. We know he's got a history of type 2 diabetes, asthma, and high blood pressure, but this was something totally new, and it was escalating fast. The clinical team, they had a real emergency on their hands.
Now here's where it gets really interesting. How did the team even begin to piece this puzzle together? Well, you start with the clues. You start with the lab work. In a situation this chaotic, you have to follow the data.
And the first major clue was just, wow, a jaw-dropping blood glucose level of 650. That's more than 6 times the normal limit. This immediately screams that we're dealing with an extreme diabetic crisis. But the question is, which kind?
And here's the twist. You'd expect with sugar that high, you'd see ketones. Ketones are these acids the body makes when it's running fat for fuel instead of sugar. But his urine had 0 ketones. This is such a critical piece of evidence because it points away from the diagnosis you might expect, diabetic ketoacidosis, or DKA. So, if it's not DKA, what is it? Well, this next clue is key. His blood osmolarity was 324, way above normal. This basically means his blood was becoming dangerously thick and concentrated. You can think of it like syrup. This condition, called hyperosmolarity, totally explained the severe dehydration and was a huge driver of his confusion and seizures. All that sugar was literally pulling water out of his cells and into his bloodstream. And the full lab panel? It painted a picture of a body under just a massive amount of stress. His white blood cell count was through the roof, signaling a raging infection. His troponin levels were sky high, which means he was having a heart attack right then and there. And, to top it all off, his potassium was critically low, putting him at risk for a fatal heart rhythm problem.
An ECG confirmed what the labs were screaming. His heart was in serious trouble. This just shows you so clearly that this was not just a sugar problem, not at all. The patient was fighting battles on multiple fronts at the exact same time: metabolic, infectious, and cardiovascular.
So, how does all of this fit together? All these clues were building towards a final and incredibly complex diagnosis. They weren't pointing to a single illness, but to a perfect storm of interconnected crises.
The central diagnosis was hyperosmolar hyperglycemic state, or HHS. This is a really deadly diabetic emergency. It's often triggered by an illness or an infection in older adults who have type 2 diabetes. And it's the one diagnosis that perfectly fits the extreme blood sugar combined with that critical clue, the absence of ketones.
So how is this HHS different from the DKA that more people have heard of? Well, in HHS, the body has just enough insulin floating around to stop it from making those acidic ketones for energy. That's a good thing, it prevents severe acidosis. But it's not nearly enough insulin to control the sugar. So HHS becomes a crisis of profound dehydration, not a crisis of acid.
And here's the crucial point. The patient wasn't suffering from one problem, he was suffering from 5 life-threatening conditions all at once. The HHS was the big one, but it was triggered by urosepsis, a severe infection that started in his urinary tract. That stress in turn caused a heart attack, which pushed him into heart failure, and then caused respiratory acidosis. It was a terrifying domino effect.
So with the diagnosis crystal clear, the team faced an unbelievable challenge. How do you treat all these competing problems without making any of them worse? This was a true high-wire balancing act, where one single wrong move could be fatal.
And this was the central dilemma, right? The main treatment for HHS is to give lots and lots of IV fluids to fix that dehydration. But giving a ton of fluid to a patient whose heart is already failing could literally flood their lungs and cause them to drown. What do?
The treatment had to follow a very specific, careful order of operations. First, cautious fluid replacement, watching his heart and lungs like a hawk. Second, fix that low potassium before you even think about insulin. Third, and this is so critical, delay the insulin. And finally, you attack the root cause with powerful antibiotics.
This right here is the most counterintuitive and crucial lesson in managing HHS. It feels wrong, but in this state, that extremely high sugar is actually what's holding fluid inside the blood vessels. It's the only thing keeping the patient's blood pressure from completely crashing. If you give insulin too soon, sugar rushes into the cells, water follows it, and the patient's blood pressure can just bottom out. So in HHS, fluids are the first and most important medicine, not insulin.
And what about the heart attack? Well, sending a patient this unstable for a risky procedure like getting a stent was just out of the question. Instead, the team used a really clever medical strategy with advanced anti-clotting drugs to stabilize the heart, basically buying precious time for him to recover from everything else.
So after days of this intensive, minute-by-minute care, juggling fluids, electrolytes, insulin, antibiotics, the patient, almost miraculously, began to turn a corner. And this is the truly amazing part of this story. Against all odds, he made a remarkable recovery. Within just 5 days, the man who arrived practically comatose and on the very brink of death was stable, he was oriented, and he was eating on his own. It was a huge testament to his own resilience and, of course, to the team's precise, step-by-step management of this incredibly complex illness.
So what are the big takeaways from this incredible case? Well, first, infections are the most common trigger for HHS. Second, its bizarre neurological symptoms can easily be mistaken for a stroke. But the most important lesson? The treatment protocol is everything. Fluids first, then electrolytes, and insulin comes last. Understanding that specific order, it saves lives.
You know, this case is just such a powerful reminder of how fragile the balance is for elderly patients with chronic diseases. And it leaves us with a really critical question. How do we shift from these incredible high-tech rescues in the ICU to better prevention out in the community, to stop this kind of perfect storm from ever gathering in the first place?